Well, good afternoon. My name is David Shepherd. I'm a retired GP who managed to retire just before the pandemic. It's the best bit of timing I've ever done, medically speaking. I do some work for LLR, Leicestershire and Rutland ICB on public population health management, and I do a bit of work for Leicester University on genetics as well, so it keeps me busy. And my colleague here is?
I'm Alan Thompson. I'm a retired nurse. I worked in the NHS for about 32 years, and I've been working for Johns Hopkins probably for the last 7 years after I left the NHS, supporting our ACG system users in the UK, people like David.
Okay, so we thought we'd liven up your afternoon by introducing you to a very stunning male. You'll be surprised to know that it's not me. And funnily enough, it's not Alan either. No, it's this chap. You'll recognise as David. I don't know whether you've ever seen him in the flesh, as it were. It's a massive statue. It's an incredibly exciting and overawing sight. So what on earth has that got to do with this talk? Well, I've got a question for you. See, when Michelangelo was making this, did he discover the statue in this lump of marble that he was working on, or did he create it? Did he make it? I mean, was he sort of tapping along innocently one day in this huge lump of marble and going, oh my goodness, that's a very realistic arm. I'll spend the next 2 years uncovering the rest of this and sort of make a lovely statue. Well, of course he didn't. What happened was he had an intention. He started with the raw material, and he worked very hard to create something out of it. So he was kind of more on the creative end, but he actually had to have a really good knowledge of human surface anatomy, for example. He had to be very careful how he worked with the raw materials that he had. So what he did is somewhere between discovery and somewhere between that and creativity. And it seems to me that what we do in analysis is kind of somewhere on that spectrum too. But some people might say, no, surely not. Surely analysis or medicine or science, they're just kind of uncovering something that's already there. That's chipping away rather boringly at something and uncovering something that's already there. It's not a creative process, is it? But I want to explain to you that it actually is a creative process. Some people say that of medicine. In my profession, general practice, there was this idea that you could actually do medicine by numbers. You remember this idea that we could replace all GPs with an app? And that just sort of didn't really go very well. And I'm not the only person who thinks that. Ian McGilchrist, in his book, The Matter with Things, sort of said, diagnosis by numbers stands to experienced, can't read it, and judgment as painting by numbers does to a Holbein. And what we're doing, I think, in our work as analysts is actually creating as much as we are discovering. And I'm hoping that our talk will kind of illustrate that a little bit further. So what have we been up to? Well, we were tasked with creating a new funding formula for primary care. And this was something that we were tasked by our CEO in 2020. Can you come up with a new model? And this kind of came out of our unhappiness with the Cahill formula. We've known for a long time the Cahill formula, which is used currently to fund or to calculate GP funding, been around for about 18 years. It hasn't changed. People have been aware that it's not great. Even Cahill himself was surprised that people were still using it years later. And it suffers from a number of issues which have been well discussed. So there was that. Locally in Leicester, we've done some work on trying to make funding for GPs reflect the needs of their population a bit. And so there've been, we've done some work trying to level up the lowestly funded practices in the city, and we'd held a gun to the heads of PMS practices to try and persuade them to share their money a little bit more evenly, and a lot of those then went back to the General Medical Services contract and did away with their money. So we kind of did some work, but it was all a little bit hit and miss. It didn't have any underlying kind of process. It didn't really cohere. but it did reflect this desire and recognition that we did need to do something about the funding in primary care and try and get it a little bit more even and more responsive to need. The other problem we faced in 2020 was that we were trying to merge 3 CCGs into 1 ICB. So we had 2 county CCGs and 1 city CCG. All of them, there's always a bit of an ongoing tension between the city and county. And we had people in the city in some fairly deprived areas in the city centre, and we had to combine that into 1 organisation that covered a very some of the richest areas of England in the heart of England. So there was that we needed something that was kind of going to pull that together. So the question arose: could the work that we've been doing with people like Alan for about 4 or 5 years previously on case mix adjustment, using primary care to case mix just their work, could that help? Could that lead to a funding formula that we could work with? So, what are the principles when we started putting this? So these are kind of moral principles, if you like, ethical principles that we kind of wanted to work with. As I say, we're trying to create something out of de novo. A funding formula isn't there in the data. You don't discover it, you have to create it. So you need some principles to work for, just like Michelangelo had a principle of trying to create an aesthetic of beauty around his work. We were kind of working with a different aspect of beauty, if you like, the aesthetic of equity. So we were trying to reflect that. So we needed a funding calculation that actually reflected the needs of our population as it impacts upon primary care. We needed something that addressed the known issues of the Cargill formula. So we needed something that addressed problems to do with communication and language. We needed something that was going to address issues of deprivation. We need something that was going to address the ecological fallacy that's within the Cargill formula, because it's not based on patient-level data. And we wanted something that was objectively fair as possible. If we were going to drive this forward, everybody had to get on board with this, because this was out with the national contract. So we had to have something that was that everyone could look at, and it had to be objectively fair. Otherwise, we weren't going to go anywhere. And it's something that met the core NHS need, that we fund according to need rather than who shouts loudest. Okay. So those were our kind of moral principles, if you like. And then we went on and drew up some kind of procedural principles, if you like, that were going to sort of underpin those moral principles. So we wanted to use patient-level data. That's absolutely key, because that completely bypasses the ecological fallacy, and it's based on your actual population that then feeds through into the funding that the practice gets. The other thing we wanted to do was to base it on local and the practice's own data. The idea of that was, one, to make it fairly responsive, but also to get people on board. If something's coming out of data that you personally have put into the system, it's going to mean more to you, and it's going to get better. We thought we'd get better buy-in if we did that. We needed comprehensive data. We're trying to create a funding system for primary care. Primary care does everything, right? You need to have something that will cover ingrained toenails, cancer, psychiatric illness, social problems, depression, everything. You have to have something that's comprehensive. So that's got to have. Otherwise, you're going to have gaps, and it's not going to fund. People are going to come back to you, but you haven't funded this because you haven't taken into account that huge gap. So you've got to have comprehensive data, and it's got to be contemporary. There's no point in basing it on 4 years ago data. We've all seen how things massively changed during the pandemic. You've got to have contemporary data. The other principle we're working to is to use diagnosis as the basis for deriving our assessment of need, rather than activity. If you use activity, all you end up doing is reinforcing unfair or inequitable usages of the system if you base it on existing current data. There's got to be something more objective that's sort of common to everybody that you can use. So those are our principles. We then started using primary care data, and Alan's going to take us through that.
I am.
You are.
Don't tread on it.
I won't tread on it. There you go. I muted it. All right. You're going to hold it?
Yeah, I'll get it. Right. I can't remember whether it was Peter or Ben earlier was talking about the quality and comprehensiveness of data in the NHS. We have certainly got one of the best, if not the best, data set of any healthcare system across the world, in my opinion. And you know, we know that. We also know that we're playing catch up in terms of how we utilize that information. Within that data set, and David's already alluded to it, the primary care data set is probably the most important and comprehensive. It contains data about virtually every patient in our population in a way that SUS doesn't. So we need to make sure that we can exploit that. The problem that people like David and Leicestershire face is that the primary care data set is a very comprehensive, but it's a very complex data system, and it's very difficult to work with if you don't use a data model or some kind. I've heard some people call it a semantic layer. You know, you need something that helps you create a usable number of meaningful markers from that complex data set, and that's essentially what the ACG system is. And I'm not here to sell it, but I just wanted to illustrate that you've got a whole raft of different data sets that are fed into the grouper. The grouper works its magic, and you get a series of outputs. You get a categorization of each patient in the population based on their level of complexity and therefore their level of need, and it's based on diagnosis, not prior activity. You've got a segmentation tool, there's a disease categorization process, there's a number of predictive models, and for the people at the Nuffield, there's one in there that predicts risk of mortality in the next 12 months, which I can share with you later on. So there's all these markers that are provided, but probably the most important here and the most pertinent to the work that David and others are doing is this ability to measure complexity or need at a person level. And when you can do that, you can start to look at things like the variation in case mix or complexity mix at individual GP practices. So this is real NHS data. The population split into 5 complexity bands, which are listed at the bottom. And you can see that across a CCG, you've got practice, or you've got the CCG average level of case mix on the right-hand side. And you can see there a clear difference between the case mix of the practices on the left-hand side of the chart as you look at it, and the ones on the right-hand have a much higher percentage of people in those very high and high complexity bands. So not only can we measure, or we can now quantify and measure differences in case mix that exist between different GP practices. And the work that David alluded to in terms of case mix and case mix adjustment over the previous years is kind of best illustrated using these 2 slides. It's a high-level summary of something that's actually very complex, but that's when I worked in the NHS, when I managed an informatics team, we produced these charts all of the time. It's comparing the performance of individual GP practices against the CCG mean average for rates of emergency admissions. I guess we've all seen this, and and that's our thinking. On the left-hand side, these practices are all above the mean average. The ones on the right are doing really well, and there's an opportunity for the system to learn from those practices. However, because we can now measure need at an individual patient level, you can create the expected level of emergency admissions or A&E attendances at an individual GP practice based on the actual case mix of each of the patients in that practice. And when you do that, and this is real data, when you do that, and the expected level of emergency admissions by GP practice is represented by the red diamonds, you can see a very different picture. So it says it on the chart there, but those practices on the left-hand side that you were perhaps castigating and asking for action plans to improve their emergency admission rates are actually, on the whole, doing as well or slightly better than expected. And some of these practices on the right-hand graph that you were applauding because their rates were lower than the CCG average are actually practices with a relatively well group of patients. Their case mix is much lower. Their expected admission rates are actually lower than the actual. So it opens the door for new opportunities that aren't exposed when you use traditional benchmarking approaches. A case mix adjustment approach exposes things that aren't necessarily seen. And that's essentially the background and the essence to what David and his team then went on to do around a new funding formula.
That's great, isn't it? It's really, really handy tool. Just one problem. Not quite as simple as that. See, the problem is the data you get out of primary care isn't 100% complete. Okay, some practices are really, really good at recording stuff and will capture everything down to your ingrained toenail and your snuffly child, coded beautifully. Other practices, they'll only do the quaff stuff and nothing else, right? And that's the problem. If you think of the coded data that you're getting out of primary care as a jigsaw puzzle that gives you a picture of what the need is in the population, what you actually get is a jigsaw puzzle with holes in it, okay? And the problem is, if you use that data as it is, however good your ACG system is, which it is very good, okay, however good your case mix system is, it's going to distort the outputs. It's, you know, garbage in, garbage out, same thing. It's not quite garbage, but it's not quite usable, and that's the problem. So you actually also have to have a model to model the data model in order to discern how it is that this inadequate data is distorting your case mix adjustment, okay? And that's some work we did in Leicester over several years. But to cut a long story short, what you can do, it turns out you can adjust the data that comes out of the ACG system, and then you can then derive your case mix as it should be and compensate for the data that's missing. So you then end up with a case mix that reflects, or you hope more closely reflects, the actual distribution of morbidity within your population. Okay, and that then is your basis for creating a funding model, because you've then got a measure of what the distribution of need is in a population. So what's the process that we then went through to try and devise a funding formula? So we know where the illness is distributed. What we needed to do next was to develop a currency of need. That is to say, something that would allow us to measure what the impact of that morbidity would be on primary care, because the different morbidities impact different parts of the NHS system in different ways. So if you think about it, a child with a snotty nose, okay, children with snotty noses are going to impact on primary care quite heavily because they get high temperature, mums bring them along to see the doctor and so on, okay. But these people aren't going to end up in the secondary care system. So their impact of snotty children in the secondary care system should be, if GPs are doing their job properly, should be really low. But on the other hand, if you have a triple AAA and you rupture your aortic aneurysm, the impact on secondary care is going to be massive, assuming they survive the first 10 minutes, all right? But the impact on primary care subsequently is actually going to be quite low. It's going to be similar to having someone with high blood pressure and raised cholesterol, actually, ultimately, assuming they get out of hospital. So you have to have a way of adjusting for that. Okay, so we developed a currency of need, which we called the expected appointment demand, and we were able to derive that using our System 1 data across 260,000 patients of our 1.16 million that was linked to the ACG system. So we could then get a measure of how many appointments a given level of need was going to need to attract for every level of need within the ACG system. So you take that weighting, you then multiply it by your ACG cell distributions, and that gives you a measure for that practice saying, this is what we would expect this practice to need in order to meet the demands of its particular case mix adjusted population. We derived this from our data, but fortunately with contacts with the ACG, we had contacts in Sweden who use the ACG system to fund their primary care. And so they had already done some of this work and created a weighting system. So we were able to compare our weighting system with their independently derived weighting system with a completely different healthcare system that sort of matched as best we could. And there was a very high correlation between the two, which reassured us that actually we were probably on the right track. So that creates a case mix adjusted, coding adjusted estimate of what the need of that practice is going to be. We then chucked in a few other adjustments as well, because we've known, and the Cahill formula has recognised this for a long time, patients that recently joined the practice tend to have a much higher, well, not much higher, but a higher usage of primary care services in the year after they joined the practice, compared with patients who've been registered for longer. So you need to build in some modification for patient turnover. And of course, this particularly affects practices in very deprived areas with lots of turnover and churn, but also student health centres, which has been a long-standing problem with any funding formula. So we built in a further adjustment for patient turnover. The other problem that we have, particularly in Leicester, of course, is communications. We have a lot of people whose first language isn't English. And if you're trying to deliver an equitable primary care service to a population, the fact is, it just takes longer to deliver the same standard of care to someone who doesn't speak the same language as you, because you have to get translators in, you have to take that time over it, you have to clarify stuff, it goes round and round and round. But we broadened that out to more than just language, because actually, of course, there's people with severe learning disability who often need additional language support and communication support. People with deafness often need additional communication support. So we broadened it out and we developed a code set and a search strategy to identify, again, from our locally coded data, what proportion of the population in each practice were going to need additional language support and communication support. So we again made an adjustment for that. And that gives you a kind of case mix adjusted, turnover adjusted, coding adjusted, communications adjusted estimate of how much need there is in that practice population as it's going to impact on primary care. So that was a chunk of the funding formula. And that was about 90% of the needs element. And then we took into account the effects of deprivation as well on 10% of the plot that was down to the needs assessment. So we took into account deprivation using IM&D scores, and that combined with what we decided to be a core level of funding that each practice needed in any case, whatever their level of case mix. We added that in, and that then went to the finance team, who were then able to work out what each practice should get. So that's the kind of system in broad outline. There's a lot more to it than that, but that's the rough outline. So, saw a lot of people. You're in a room of analysts. If you just do words, they're going to get twitchy. And a couple of you were twitching a little bit. I thought I'd better put up a graph, get them happy, right? So this is the kind of breakdown of how it kind of packs out. So let me explain what this means. So the red line is basically the baseline starting point where all our practices started from without any funding change on the existing funding system. The blue line is where they ended up when we case mix adjusted, coding adjusted, deprivation added, all the rest of it. Okay, so the orange dots are where they would have ended up if we didn't adjust for their coding deficits. And as you can see, if you don't adjust for coding, it really pushes the practices apart. And these ones along the top line are generally practices that code well. The ones below the blue line are ones that don't code so well. So we bump them up. And in the process, of course, because one thing you do changes everybody else, it brings them down. So you end up on the blue line when you just coding. And that accounts for about 4% dispersion either side of that blue line. Okay. So if you don't case mix adjust, but you do everything else, that accounts for 12.5%, 12.5% dispersion there. So there's so you can see the effects. The case mix adjustment makes a big difference to where practices end up on this funding thing. Turnover's much smaller, but if you're one of the practices that's majorly affected by a huge turnover rate, it's important to you. And that's been one of the bugbears of the old funding system. The same argument goes for communications. Most practices don't have many patients with severe communications problems, but some do. We have one practice for 54% of the population has to have additional learning needs. It won't surprise you to learn that that's our asylum seeker service. Okay, so it does make a difference to some practices, and so we're trying to bring in all the elements that affect lots of different practices to try and to solve the issue. And the last one is deprivation. Again, if you added deprivation, that also makes quite a big difference on where you'd end up without it. So that's kind of how it sort of stacks up. Politics, can't get away from it. Did you know that when Michelangelo finished his statue of David, right, they had to put a guard on it because he was worried about the other artists in Florence at the time who were hacked off, that he got the commission and they didn't. And there were people who were seriously going to damage it. And there's stone damage on David's back, apparently, from people who tried to harm it. So you can't get away from the politics, even if you're a wonderful, creative person like Michelangelo. You certainly can't get away from the politics when it comes to primary care funding. Absolutely no chance. So how on earth do you get 130 GP-led organisations to agree to be led on something voluntarily? I mean, I'm sure you've all heard it said, leading GPs is like herding cats. It's very hard. Three answers. One, money. Okay, money talks. Okay, and our wonderful finance lead in the ICB at the time, Nikki, came up with a no-loser arrangement and managed to claw some money out of the rest of the acute system. Something we in primary care have been screaming about for years, and she did it. So we negotiated a no-loser deal. So those practices on the right-hand end of that chart, who were kind of going to lose, apparently, they don't. They get what they would have got anyway. That's how you get everyone to agree. So all the people that get a gain, the people who would have lost don't lose. And then it's pretty churlish of them to then say, no, I'm not going to sign up to that when you're not losing, and you're going to deprive all your colleagues of money they've needed for years, and that we've got an objective system that proves they need it. Okay, so that's how we kind of got that one. But you've got to have a common aim. Our common aim was, to have a trusted, credible plan. It's got to be solid because it's going to get kicked, right? And people have kicked our system, or tried to kick it quite hard. Okay, it's survived so far. So you've got to have that, and you've got to consult, engage, and then engage again, and continue engaging. And we've been at this for 2 years now, and we're still engaging. Okay, so the formula was implemented in July 21 for an agreed 3-year period. So 114 million was distributed across our 132 practices, covering 1.16 million patients. 76 of our practices saw a 2.8 million increase in their funding derived from this model, which they've been screaming out for ages. And we're assessing the outcomes as we go along. You want to say that?
Yeah, David and his team are far too modest to say this, so I'm going to say it. This is an incredibly seminal piece of work that's using primary care data in a completely different way. I only know of 3 publicly funded healthcare systems across the world that do something similar. So David's work's not only attracted the attention of people at NHS England and other parts of the NHS, but he's spoken to people in Portugal and Italy and Sweden and other places as well. So it's an incredibly important piece of work, and it shouldn't be underestimated. And I think they should be lauded and congratulated as much as they can. We did write the work up, and there are some handouts there on that table. Please take them, then I don't have to carry them back to the train station. And also, just on the theme of end-of-life care, we've just published this study, a piece of work that was done with Dorset ICS that's pertinent. I've got a few photocopies of that if anyone is interested. So thank you for listening. Happy to take a question.
Thank you very much. I just found that fascinating. Oh, we've got a hand up already. Lady in the blue. Hi, I'm from Cambridge.
We met with your guys the other day.
Oh,
yeah. All right.
But that was fantastic. Really interesting. The last bit. How did we take the public?
What? Oh, don't. It's hard work engaging with GPs. We didn't engage with the public, actually, interestingly, because this is about funding primary care services. Maybe we should have done that. I mean, no one's asked me that yet. Oh, they really care about funding. They certainly care about being able to see their GP. And that's why we chose that particular currency of, you know, appointments as the funding currency, so that we fund according to the needs for that. Yeah, I mean, I'm hoping that through the processes of the annual patient experience survey, we will start to see improvements in that. So we kind of, bit of a cheat, we will engage with them indirectly.
Please.
I was looking at your slide about the difference when you compensated for the missing data model.
Yes.
It's quite big. Could I ask you how you did that? Is it a multiple imputation kind of approach, or were you assuming it's something like clusters, which are kind of random inserts?
No, yeah. This is a 4-hour lecture. When I tried to explain it before.
We've got 1 minute left.
1 minute. Okay. Maybe if I talk to you about it afterwards, unless anyone else is desperate to hear. You are desperate to hear, right? Okay. Okay. The thing about the ACG system is that it's got a very clear structure. So the way in which the data flows through the system is very clear and logical and follows set rules. Okay. So what happens is, if there is missing data, what tends to happen is that patients will drop down from one category to the next category, to the next sort of you know what I'm saying, right? The next category and the next category. So what you can do, if you get, and what we were able to do, we were able to identify by another means, which were our really good coded practices and which were our poorly coded practices. I can explain how we did that. And then what you can do is you can take the ADG data that feeds into the ACG system, and you can model how that change in data causes the final output to change. And then when you've done that, yes, so it's a sensitivity analysis, really. So, but what we did was technically we did a Monte Carlo model of the way in which the data is dropped down in the ACG system. Okay, and then once you've done that, you can then reverse engineer it to calculate roughly what practices should be and estimate what it should be.
Thanks.